This is a very, very exciting area. I know many of you are urologists and radiation oncologists. I don't know if there are any medical oncologists here, but I think that there's a tremendous amount of research coming out in this space, and it's hard to keep up with it, and I apologize. Some of my slides may look a little dense, but I'm going to give you the bottom line about really where I think these genetic and genomic tests are going to make the greatest difference. You already had a talk earlier about Oncotype and Prolaris and in the decisions around active surveillance. Some of you may use Decipher. I think we're talking here about something very different that Dan has already alluded to, which is the use of systemic therapies on the basis of genetic changes, and really whether or not you should be testing your patients for both germline and somatic tests on their tumors, because I think that as it turns out, we all think of prostate cancer as a single disease, but molecularly, prostate cancer is multiple diseases, and that's why we're going to start subdividing them. This has already happened in lung cancer. It's happened in breast cancer, and it's going to happen more and more in prostate cancer, so that we're going to treat those small percentages of patients with certain kinds of prostate cancer with specific drugs. So if we think of prostate cancer as a very heterogeneous disease ranging from a localized, hormone-sensitive patient who's curable with treatment, Gleason 6, all the way to this aggressive neuroendocrine type phenotype or Gleason 10 cancer that becomes castration-resistant and dies. You know, the fact that they all anatomically start in the prostate really is not enough to necessarily say that these are the same diseases, and we know based on their outcomes that they are different clinical entities. Now the question is, we used to use this term clinical pathologic. So, the fact that we're still using Gleason scoring is a little bit embarrassing if you think about it. This is technology from the 1970s. And, all of you are hearing these terms, genomics, transcriptomics, proteomics, epigenomics, metabolomics. The omics concept is that we're looking molecularly at these cancers and trying to identify the things that really group these patients and these tumors in a unique way that's not just based on histology. Why do we still use histology? Why are pathologists still so important? Why are these clinical entities still the way that we monitor these patients? Because these have not yet fully integrated themselves into clinical practice. But if you look at other disease types as an example of where we're heading, we are going to definitely move in this direction. I don't think there's any question about it. So I'm going to show you a few what look like busy slides, but they're actually they're going to be quite simple and a little bit hard to see. But basically, the TCGA is a very famous cancer atlas that started about 20 years ago to map every cancer. Now, in prostate cancer, if you look here, there were only 333 primary prostate cancers that were mapped. And you can see the different boxes. They looked at mutations, copy numbers, and they found these different. I'm going to summarize this in a little while, so you don't have to look at this slide. But that one study of 333 prostate cancers was basically the only thing we really knew about the genetic abnormalities in prostate cancer. And if you notice, when you look at this one in primary prostate cancers, the abnormalities that are the clinically relevant abnormalities are actually pretty rare. Prostate cancer is not a very mutated cancer. So if you look at that concept of microsatellite instability that Dan just brought up, it's 3%. So in certain diseases like colon cancer, it's like in the 20s or 30s. There are many, melanoma is highly mutated. Lung cancer, highly mutated. And it turns out those are the cancers that are actually the most susceptible to immunotherapy, because what happens is they create so many of these so-called neoantigens, these little proteins that your body identifies as alien, that you can make vaccines and actually target them. What happens in prostate cancer is it's actually not a very mutated cancer. So when they looked at these primary tumors, it's a little hard to see, I apologize, but it's BRCA1 and 2, CDK12, ATM, some of the things that you just heard Dan talk about. And then the most common genetic abnormality in primary tumors is a loss of PTEN. PTEN is a tumor suppressor. So if it's normal, it keeps the tumor at bay, and when it's lost, it actually allows the cancer to grow. And these are all in the PTEN pathway. So in these early papers, which actually are not that long ago, it's 2015, which shows you how long it's taking for the genetic revolution to really influence what we know. These are on 330 prostate cancer patients. Took them that long, 15 years, to do this. And so in 2015 also, we actually got a more important paper, which was mapping metastatic CRPC. So if we think that localized prostate cancer is a much larger pool, of which we've only sequenced 333, the people who we really care about the most are in terms of dying of cancer, are the metastatic CRPC patients. You remember in my curve, only a small subset of these patients ultimately progress and die. So what this paper showed was, in fact, if you actually go, and this was about 250 men, and this study, by the way, cost millions of dollars, funded by Stand Up to Cancer and the Prostate Cancer Foundation, cost millions of dollars to basically biopsy men with metastatic disease. So, you know, the biggest problem with prostate cancer is that we usually only get tissue at one time in that person's life, right? At the time of biopsy, and sometimes if they have their radical prostatectomy. We've been, I'd say, hindered by the fact that we don't do serial biopsies in men with prostate cancer. Will that change in the future? Actually, it's already starting to change. But prostate biopsies or bone biopsies or lymph node biopsies are still difficult to get. Often painful if you're talking about the bone, often of poor quality if you're talking about the bone in terms of getting high-quality DNA, and usually you don't need it in order to make a clinical diagnosis, which is different than many other diseases. So we've been very hindered, and this study, the Stand Up to Cancer study that I'm showing you here, basically made a point of biopsying these 250 men with metastatic lethal prostate cancer. And they went and biopsied, instead of just relying on the prostates to say what are the genetic changes that occurred 10, 15 years later, they went and they actually biopsied those genetic lesions. And if you look here, again on the, what you see on the bottom here are the CRPC enriched genetic abnormalities, and on this side, the primary enriched. And you see there are some genetic changes in the primaries, which I'm not going to talk about. I mentioned P10, but there are several others. There's also the BRCA2, which I'm going to talk about a little bit more. And as you move to the most aggressive cancers, there's only one that kind of sticks out. There's actually two. AR, which we know. This little circle of AR mutations and activation, believe it or not, is what's led to enzalutamide, abiraterone. All of these drugs are because people recognized that androgen signaling was still important even when you become so-called hormone refractory. And that's what is represented in this bubble. And P53, unfortunately, even though we know that it's the most important tumor suppressor, so P53, like P10, is also a tumor suppressor, you see that it's mutated or abnormal in the vast majority of men as they get this very aggressive, lethal phenotype, and yet there are no drugs that target P53. And then you see it's kind of a desert for information. There's nothing else here genetically that we can target besides AR, which is right here. And then what I'm going to talk a little bit more about is the DNA repair abnormalities. So we are making progress, but unfortunately it's really not necessarily giving us a lot of new information about new targets. So this is a very famous figure that's been shown, that you'll see if you go to any science talks, but basically these two guys, Hanahan and Weinberg, published basically a diagram that defines all the different kinds of ways that cancer grows, all the scientific ways that cancer grows. And I modified, so for example, it can resist cell death, it can deregulate energy use, it can evade growth suppressors. So you can see all the different ways, and then what you see on the outer circle are the ways that drugs can actually target them. So I modify, like for example, what Dan just talked about, cancers can avoid immune destruction. As he said, I liked his analogy about how they hide from the immune cells. They can actually be found out by these checkpoint inhibitors. But I'm going to talk a little bit about this area right here, the PARP inhibitors, because Dan mentioned it. And this is a part of the cancer susceptibility related to genomic instability and mutation. Well, first let me start with one of my patients. This is a patient I saw pretty recently. 59-year-old. He presented with hematuria, a pretty low PSA, 3.6, Gleason score of 9 with an intraductal component. His imaging showed a bulky prostatic cancer, multiple pelvic nodes, and one pubic ramus bone lesion. He actually told us that he had a very strong family history of breast and prostate cancer, and knew that somebody in his family might have a BRCA mutation. And indeed, we found that he had in his tumor, which we sent, his primary biopsy showed a BRCA pathogenic mutation, as well as a PTEN and RB loss. RB is another tumor suppressor. We started him on ADT. Based on this kind of aggressive presentation, and given his young age, I gave him docetaxel. We may still give him abiraterone. You remember latitude versus charted, we could use either. And we sent germline testing. So one of the questions that we had was, should we add additional treatments because he turned out to be a germline BRCA2 carrier? Should we add abiraterone? And should we add this so-called PARP inhibitor? And I'm going to show you some of that data. The other question that comes up in a man like this now, and Dan didn't go over the data presented in Lancet last year, but a Stampede did show that treating the primary in a patient like this who would be considered to be oligometastatic might actually improve his survival. So we are planning to radiate his prostate and pelvic nodes, but the question is when? You know, he's in the middle of chemotherapy now. How do you sequence these different options appropriately? So this one patient brings up a lot of what we're learning. First of all, we know this guy's at very high risk of dying of his cancer. We know that. And we finally found a couple of additional ways of targeting him besides local therapy, besides what we know about chemo and abiraterone. Can we incorporate drugs like PARP inhibitors? And I'm going to show you the data on carboplatin, which are maybe ways of attacking the BRCA2 nature of his cancer. So what is this whole DNA repair alteration story? Well, many of you know who most famously made this a big story was Angelina Jolie, and I bring it up in my clinic when I'm talking to the patients. I tell them Angelina Jolie had her breasts removed and her ovaries removed because her mother died of breast cancer at an early age, and she has a BRCA1 germline mutation. That means that she inherited from her mother almost a 99% chance of getting breast cancer in her lifetime. And so people did not think that these genes were related to prostate cancer, but it turns out that about 23% of men with metastatic CRPC actually harbor a DNA repair alteration, the most common of which is, in fact, BRCA2, which you can see here on this side. So they can have other ones. They can have BRCA1, they can have ATM and CHEK2, which you've also heard, but BRCA2 is by far the most common abnormality in these men. 23%. In that study from Cell that I showed you earlier, that's 1 in 5 men with lethal prostate cancer will have a BRCA2 mutation. It also is interesting because it does seem to increase as the cancer progresses. So you might not see this in their original prostate specimen, but it may be present in their metastatic lesions as they progress. Of those 23%, about half of them, or about 12%, are germline. So that means 1 in 5 will have this mutation, and out of those, half of them will have inherited a predisposition or BRCA mutation or germline. And the other half will have had a somatic mutation, meaning it happened during their lifetime. They did not inherit anything. Remember, the germline test is easy. You can send them to a genetic counselor. You can also, there are lots of points of care consumer testing now, like 23andMe, which I would not send to. It has a very bad reputation, very small number of genetic mutations they look at. But there are some more reputable consumer genomics companies like Color.com that they can actually, for $99, get their BRCA2 testing done. But the best companies are companies like Ambry Genetics and Myriad that have been around for a very long time, and you can send them a swab, and they will, as a physician, you can order this test, and they can do a comprehensive germline panel. But as a physician, you can start by sending the tumor, and you can see if the patient has a BRCA2 mutation or one of these other DNA repair abnormalities. Okay, so what is the story with Olaparib? Because, in fact, you may know that Olaparib and many more PARP inhibitors are coming, but Olaparib is actually already approved in the United States and worldwide in women with breast and ovarian cancer who have a BRCA1 or 2 mutation. So if they have a DNA repair abnormality, they can already get Olaparib. That's why it's commercially available. But in men with prostate cancer, this study was published in the New England Journal. If you have, they called it biomarker positive. That means that you had one of these DNA repair abnormalities in your tumor. If you whether it was germline or somatic, if you had it, you had a much better rPFS, and you actually had a much better OS if you received Olaparib. Olaparib is it basically interferes with the DNA repair, and so only works particularly in these patients with these DNA repair abnormalities. So based on this smaller phase 2 study, there is a large phase 3 study going on right now. If you have one of these DNA damage repair. You're going to see a lot of these, people use all these different abbreviations. You'll see HDR, you'll see DDR, you'll see different abbreviations for what we're all talking about are similar, which are that there's basically for prostate cancer, basically a BRCA2 mutation. So there was an interesting other study, though, which looked at Olaparib and plus Abiraterone in patients who actually did not have these abnormalities. So they didn't select anyone with a DNA repair abnormality. They just gave them Abi with or without Olaparib. So you see both arms got Abiraterone, but half of them got a placebo, half of them got Olaparib. Even without selecting, there seemed to be an improvement in overall in progression-free survival here. Overall survival doesn't look very different. So this is also being studied based on this early data in a larger phase 3 study in those who are genetically unselected. So it's possible that we don't have to, those are very complicated graphs I showed you earlier. Lots of different genes. Do we have to memorize all those, or will we actually have a test, a companion diagnostic that will tell you that this patient's a candidate or not? Or in this case, maybe it doesn't matter. Maybe you can just give everyone Olaparib plus Abiraterone and see a PFS benefit. As I said, besides Olaparib, there are a lot of other companies developing PARP inhibitors. This is Rucaparib, and you can again see I'm only mentioning BRCA2 because it's the most common, but you see there's a whole host of these different germline mutations, and they give these drugs and they assess for response. Now, one interesting thing in this study that they saw called Triton-2 is that they did look at these other 2 mutation types, or 3 types, and you can see ATM is one, CDK12, Dan spoke briefly about. But in fact, the only patients who seemed to respond were the ones with BRCA1 or 2 mutations. So that's probably the single most important one, and one that you can help identify in your patients. The other interesting thing, I don't have a slide on this, is a paper just came out in JAMA Oncology from Oliver Sartor, that if you only look for patients who have very strong family history, so if you're looking for a guy whose mother and aunt and sister all had breast cancer in their 40s, they will be more likely to have this. But in fact, about 60% of the people who carried these mutations, these germline mutations, had no significant family history. A lot of people, as you now know, you're reading in all the time, they're not even related to the family that they thought was their family. And in fact, a lot of times people have died from other diseases, and you may not know. So the argument is moving towards the concept, and you may see this in the guidelines, that we should start screening everyone. Because if you have these mutations, it has significant consequences for your therapeutic outcomes. So here, if you look at these swimmers plots, this is just the BRCA2 and 1 patients, and you can see that these are pretty substantial durations of time on treatment. In fact, you see that they had only about an 11% overall response rate. All of them were partial responses, but about 36% of the patients actually had stable disease. And you can see that some of these people had ongoing benefit going on half a year to a year. The other thing is that there's a bias that people tend to think that this is just Ashkenazi Jewish patients. That's really not true. I'm in New York, and I see a lot of different diverse types of people, including Ashkenazi Jewish families. But I recently took care of a man who was an immigrant from Korea, and his son had actually sent off a germline test because he knew that his father and 3 of his uncles had prostate cancer back in Korea, 2 of whom had died. And we were in the middle of radiating his bone metastases, treating him with Abiraterone, and he had already gotten chemotherapy once. And so in the midst of this, he was found to have a BRCA2 deleterious mutation, but it was different than the one seen in Ashkenazi Jewish patients. It was identified in a unique cohort in families in Korea. So they may actually have different mutations, but in the same genes. So you can see it's very complicated, but the key is that this drives this whole DNA repair pathway, and there are all these different drugs that may target it. Now, if you can't get a PARP inhibitor for your patient, and you may be able to, but they're very expensive, it turns out that for many years I've studied the drug Carboplatin. This is an old and very cheap drug. It's like $100 an infusion, believe it or not. It's generic, and it's been around for many, many years. I have been giving and doing trials with platinum, but didn't understand why it worked. We always knew that about 20 to 30% of patients seemed to respond to platinum-based chemotherapy in prostate cancer, but we could not identify who those were. So this was a study done and published in Cancer by one of my colleagues at Dana-Farber that I was part of, where he went back and he looked at the germline DNA of these patients. We treated a total of 141 patients with platinum-based chemotherapy. Now, many of them also received taxanes, but when you look at their age, you see they're younger. You see that they don't have a difference in family history of prostate cancer, but they do seem to have more breast and ovarian history. And you can see they start chemo at an earlier time, probably because these BRCA cancers are more poorly differentiated. But what's interesting is they have a 75% PSA response rate to platinum-based chemotherapy compared to the group that are non-carriers, non-BRCA carriers. Very statistically significant. And we know this from breast and ovarian cancer as well, that women, for example, who have a BRCA mutation are much more likely to respond to platinum chemotherapy. So this is really an option. And remember, in the case of my patient, I'm actually giving him docetaxel and carboplatin together because we know how to give those safely, and given how aggressive his cancer really is. So to summarize this area, DNA damage repair mutations are common, about 25% total, 12% in the germline. They're highly responsive to PARP inhibitors, and you're going to see and hear more about this in prostate over the next few years. They may actually synergize with abiraterone even in unselected patients, but the bottom line is you should be testing your mCRPC patients for DNA damage repair mutations. And you can do this by sending off their tests to a commercial lab, or you can do it by doing their genetic germline testing, either consumer labs or actually send them to a genetic counselor. Okay, so let me talk about briefly about a second patient of mine. He's a 66-year-old man with metastases who who has an AKT mutation. So you see he's had PSA of 22, he had bone metastases, he had a Gleason 9 cancer in every core. He started Firmagon, Abiraterone, and prednisone, and he actually later developed, about 6 months later, was still having severe LUTS and had a prostatectomy, and in fact, his urinary symptoms improved. His PSA nadered to 0.2 but started rising. And you see it actually is higher than that, 0.15. It should be actually 0.4. It went up to 0.4. And he developed new liver mets with a PSA of only 0.4. So when his prostate came out, we actually sent that for molecular testing. And in fact, what we found was that he had an amplification of AKT1. This is a driver mutation of prostate cancer. It's extremely rare. Now, you can't really see it, but this is in other tumors, AKT mutations. You can see it's extremely rare. But if you actually look at other diseases like breast cancer, gynecologic cancers, and other, you can see that if you have the mutation and you give an AKT inhibitor, you have these very, very dramatic responses. So in other words, even though this is a very rare tumor, if you find this patient, you give them this drug, then they're going to have a response. It doesn't matter the type of tumor. What matters more is the type of mutation that the person has. So in fact, we sent him to this study at our neighbor Memorial Sloan Kettering because we did not have this study open, and he was eligible for this and actually has started on treatment, and his tumor is actually shrunken after only 3 weeks on therapy. So what you're going to see is that different patients will actually start to, we're thinking of this as an N of 1 type of story. In other words, you see all these problems on the left. There are patient factors. The guy has to be young enough and healthy enough. The tumor alters over time. You have complex networks and a lot of heterogeneity. But can we start to select individual patients for individual therapies based on their genomics? The most common story right now is BRCA. Right? That's about a 20 to 25% of the metastatic CRPC patients. But you can see that in that example I just gave, there are going to be more and more of these small individual examples. The other one that Dan gave was probably a very appropriate one. 3% of patients will have MSI high tumors. 3%. You can actually order a drug for them, FDA approved, pembrolizumab, because if you have a microsatellite unstable tumor or MSI high tumor, even though it's only 3%, they have a very high response rate to immunotherapy. All right. So I have one more topic I wanted to talk about, and I don't think anyone's talked about lutetium-177 yet, right? Is that right, Neil? Okay. Let me just give you a few slides on this. It doesn't really fit the rest of my talk, but I thought it was an important new area that you'll be hearing more about. I think you did hear about PSMA PET scans, But the question is, what do you do with that information? Is it just an early imaging test? One of the reasons people are particularly interested in this is because you can now take PSMA and link it to a small molecule, the small molecule PSMA 617 to lutetium-177, which is a therapeutic radionuclide, right? And so this was a study published in Lancet Oncology by the Australians. These were heavily pretreated patients who received this Lu-177 PSMA therapy, and you can see a very, very impressive waterfall plot, very impressive. Now, it does have side effects I'll show you in a minute, but the overall response rate was about 62%. So there are ongoing studies in the United States looking at lutetium-177 PSMA, and this is the overall survival you can see here in the 30 patients that they have the data on. It does cause side effects, including this kind of really mild but can be very bothersome dry mouth, because it turns out there are PSMA receptors in your salivary glands. So it kind of burns that out a little. They get some leukopenias as well. But in general, it's pretty well tolerated. And so we're part of this VISION study. This has now been brought to the United States. It's a randomized trial of this agent versus best supportive care in patients who are PSMA positive. Maybe about 70 to 80% of mCRPC patients will actually be PSMA positive. You have to have a high enough volume of disease, and you can't have a burden that's not PSMA positive. And you can have received either Enza or Abi and at least one chemo to be eligible for this trial. So this is my last slide. Genomic sequencing of tumors may elucidate rare gene targets for therapy. The DNA damage repair is the most important, but these other types of rare abnormalities, like I gave you the AKT1 example, you're going to see more and more of, and it's going to be more and more complicated. Hopefully you can work with oncologists in your communities who are really engaged in this space, but you as the primary doctors have to really screen them for these abnormalities, otherwise you won't even know. And then I do think you're going to be hearing more about Lu-177 PSMA therapy in the next few years, because these studies are ongoing, and I think patients are going to be asking you. It's very promising new therapy. So I'll stop there. Thank you very much.